What's wrong?
Oh no. I went through the acetabulum.
Hold on. Back up the corkscrew. Have a better look.
Okay. We just
All
have
right.
a home
Let me
real quick.
adjust the light.
Yeah, please.
All right. Let me reposition the leg for you.
Thank you.
All right. Just make sure you're in the center of the head.
Okay.
All right. And just pull the head out like this. Yeah, just like that.
There it is.
Perfect.
Save that for sizing.
Okay. What's going on?
So, just move the light a little bit. Yeah, it looks like I went through the head and I'm partially into the acetabulum a little bit. So I overscrewed and damaged the cartilage.
Really? That's not good. So
No.
what were you trying to achieve, and what are you doing now?
I was trying to get it into the center of the head, but I don't think I was. I think I was a bit to the side, so I was eccentric, screwed through the head into the acetabulum, damaged the cartilage surface. So at this point in time, if we convert to a total
Okay.
hip and with a possible bone graft, we should be okay.
Okay, good. Let's start with that. Remember, for your exams, you need to get consent for a hemiarthroplasty and a total hip. That's the standard of care. And when you're prepared for the complications and you talk to the family and the patient about what may happen, that sort of prepares them in case something does happen.
Okay, so Dr. Morris, we're going to go ahead and switch to a total hip, so we'll probably be adding about an hour at most onto the case, most likely about half an hour. So we'll need the reamers and we'll need the template prosthesis.
All right. Well, complications do happen. Don't let it shake you. Just regroup, rethink, and repair. You just have to be able to recognize when a complication does happen and know how to deal with it. So I always think about the case before I start it and go through the mental process and make sure that I think about all the possibilities that could happen. So you've done total hips in the past?
Yes, I've done several.
All right. You're a senior resident. You should be able to handle it. Do you feel comfortable continuing with this case?
Looking at the surface of the cartilage, it looks pretty good. So we should be able to do it with a nice total hip. Shouldn't be too difficult for a procedure. So I've done several of those in the past. I should be good to do this one.
Okay. So let me take a better look at that acetabulum to see what's going on, what kind of defect we have. Okay. It's not that large of a defect. I think you should be able to handle this and repair the defect. We're going to have to put an acetabular component in there. So I want you to think about, how you're going to break the news to the family and what we discuss with them.
Sure. I basically need to discuss with them and the patient as well. First, I'd probably talk with the family because they'll be in the waiting room waiting. That we had a bit of a complication, but it was a type of a complication that we discussed pre-op, which is why we consented pre-op for the possible conversion of the total hip. But it'll increase the risk of dislocation, increase the risk of infection, increase the anesthesia risk, and there's an increased dislocation risk.
Okay.
So I'll talk with the patient once he's not quite groggy from the post-anesthetic medication.
All right. Well, he's my patient, so I will do all those things, but you should know how to handle that and speak to the family. But you should come with me and talk to the family. It'll be an invaluable learning experience.
Thanks, that'd be great.